Hi, my name is Navneet, and I'm doing my presentation on asthma. Moving forward to the assessment data. The assessment data, the subjective data is a 21-year-old female, lives in a small town in Northern Ontario. The patient has a history of mild asthma and is allergic to dust and pollen. The patient was unable to lie down and began to use accessory muscles for breathing. The patient's wheezing was unresponsive to her Advair inhaler. The patient is complaining of shortness of breath. The objective data includes the set of vital signs, which is the blood pressure of 150/80, heart rate of 123 beats per minute, the respiration is 46, temperature of 37.9, oxygen saturation 94% on 4 liters of oxygen by nasal prongs. The arterial blood gas results are the pH of 7.31, partial pressure of carbon dioxide is 48, sodium bicarb is 26, partial pressure of oxygen is 55. The patient is alert and oriented times 4. The patient has diminished lung sounds with inspiratory and expiratory wheezes in all lung fields, non-productive cough and use of accessory muscles. Skin is pale, warm, and dry. The patient appears to be anxious and is sitting upright, leaning over the bedside table with complaints of shortness of breath. ECG reveals sinus tachycardia with no atopy. The patient with the ABG results show that patient is having a respiratory acidosis. The pathophysiology of asthma is asthma is a diffuse airway inflammation that leads to airway narrowing, which is aggravated by a number of changes in the airway, such as bronchoconstriction and airway hyperresponsiveness. These factors determine asthma's clinical manifestations and severity. Mast cells, neutrophils, and lymphocytes play a vital role in airway inflammations. Mast cells release chemicals known as mediators upon activations. When activated, histamine, bradykinin, and prostaglandins released by mast cell extend the inflammatory response, which results in bronchoconstriction, vasoconstriction. The pathophysiology in the table with the inflammation is caused by all these factors, which will be the female gender, the others such as the allergies, occupational exercises, respiratory infection, air pollution, smoking, hyperresponsiveness of airway limitation causing the symptoms, and the risk factors for exacerbation. Moving forward to the diagnostic test that can be used is the physical examination and history. Primary diagnosis of asthma is acknowledged through a positive history, including frequent colds, shortness of breath, and allergies to dust or pollens. Physical examination consists of presence of cyanosis and use of accessory muscles for respiration and anxiety. Chest X-ray focuses on the hyperinflation of the chest and lungs and check for inhalation of any other foreign body particles. Sputum and blood test is also done to disclose increased level of eosinophils. CBC is also done for the diagnostic test. Oxygen saturation and arterial blood gases helps to reveal hypoxemia during acute asthma attacks. The increase in the partial pressure of carbon dioxide is a sign of worsening asthma attack or status asthmaticus and respiratory failure. The CT scan of the chest is done to rule out complications such as pneumonia, fibrosis, or bronchitis. Spirometry test is done to help to measure the ability of person to exhale and inhale air respective to time. It helps to assess the narrowing of the airways. The allergy blood test is done to reveal if the allergy is present. Elevated IgE antibiotics tells that an allergy is present. The risk factors would be the modifiable risk factor include cigarette smoking and tobacco use or exposure to it. The respiratory infection, exposures to environmental hazards such as air pollutants or allergen, exposure to certain food and medication, sedentary lifestyle, and obesity. The non-modifiable risk factor would be genetic predisposition or family history, atopy, which refers to genetic tendency to develop allergic diseases. Effects on other body systems such as cardiovascular system is that asthma is related to an increased incidence of cardiovascular diseases due to chronic airway inflammation. Asthma patients are vulnerable to systemic inflammation, which contributes to vascular diseases. In asthma patients, enhanced coagulation activation in the airway, impaired function of the anticoagulant protein C systems, attenuated fibrinolysis, and increased platelet activation are found. putting the patient at risk for developing cardiovascular diseases. Moreover, allergic asthma increases atherosclerosis by adjusting the balance of effector T cells and regulatory T cells. During an asthma attack, the sudden restriction of airway pathways strain the heart muscles, causing immense pain. The medication for the treatment of asthma also lead to cardiovascular events. The gastrointestinal system is affected. The patient with asthma are at a high risk of developing GERD. Asthma can cause the lower esophageal sphincter to relax, permitting stomach contents to flow back. The medication can also deteriorate reflex symptoms. The next would be diagnosis and priority problem analysis. The first nursing diagnosis would be ineffective airway clearance related to bronchoconstriction, as evidenced by shortness of breath, diminished lung sounds, wheezing in all lung fields, abnormal ABG values, and a respiratory rate of 46. The rationale for priority problem is that an ineffective airway clearance directly affects tissue oxygenation, and the body cannot provide oxygen to other cells. A clear and effective airway is essential, and necessary intervention must be used to enhance pulmonary ventilation and oxygenation to promote easy breathing and prevent oxygenation problem. The second would be ineffective breathing pattern related to inadequate pulmonary ventilation secondary to asthma, as evidenced by the respiratory rate of 46, shortness of breath, tachypnea, abnormal ABG values, and use of accessory muscles. Ineffective breathing pattern is a state in which the breathing rate, rhythm, and the depth and pattern are altered. In asthma, the constriction of bronchial smooth muscles and swelling of the bronchial mucosa leads to premature airway closure and causes an increase in functional residue capacity and air trapping. Air trapping results in ventricular perfusion abnormality, hypoxemia, and respiratory acidosis. Respiratory acidosis is a sign of respiratory failure and requires immediate interventions. The short-term goal would be the patient will be able to maintain airway patency and improve airway clearance, as evidenced by the ease of breathing, expectoration of secretion, clear breath sounds, and respiratory rate of 18 to 20 respirations per minute within 24 hours of admission. Maintenance of airway patency is the priority nursing intervention to prevent serious complications such as respiratory insufficiency and failure. The long-term goal would be the patient will verbalize understanding of cause and therapeutic management regime of asthma and asthma exacerbation at discharge time. Patient teaching is critical component in managing the complex medication regimen. Patient must understand the causes of the asthma attack, medication regimen, such as use of inhalers and puffers for long-term management of asthma. The short-term goal for priority column 2 is the patient will maintain a normal respiratory rate of 18 to 20 respirations per minute with no use of accessory muscles and no dyspnea present within 24 hours. Ineffective breathing can lead to respiratory failure, and effective breathing must be maintained to avoid tissue breakdown and acid-base imbalance. The goals for priority column 2 would be the patient will maintain normal ABG level in the body and show no sign of respiratory distress by discharge. Respiratory alkalosis and respiratory acidosis can develop in persistent asthma. Maintaining normal ABG values will help to prevent respiratory acidosis, which can lead to respiratory failure. The intervention is to administer the prescribed asthma medications such as bronchodilators and corticosteroids. Administration of bronchodilators such as Albuterol helps relax the airway smooth muscles and relieve asthma attacks. Corticosteroids help in reducing inflammation and managing asthma symptoms. The patient must be educated on using inhalers and puffers. Nurses must demonstrate proper inhalation techniques and inform patient about triggers to avoid symptoms of an asthma attack and when to seek assistance. The second intervention is to monitor the patient vital signs every 4 hours and evaluate the rate, rhythm, and depth of patient breathing. Frequent monitoring of vital signs help in assessing the sign of hypoxemia, such as elevated heart rate and blood pressure. Change in the breathing pattern is a sign of respiratory distress and needs to be treated immediately. The evaluation: the patient maintained an oxygen saturation of 96% on room air, verbalized ease of breathing with no shortness of breath, and is experting phlegm within 24 hours of admission. The patient demonstrated the proper use of inhalers and puffers and verbalized the sign and symptom of asthma exacerbation and irritants that can cause asthma attack. The patient verbalized the definition of bronchoconstriction and inflammation and the purpose and action of medication by discharge. The patient maintained respiratory rate of 18 respirations per minute and is breathing comfortably with no use of accessory muscles within 24 hours of admission. The long-term goal is the patient ABG values were within normal limits and patient had no episode of respiratory distress by discharge. These are the references. Thank you so much.